She sells seizures by the seizure shore. Susie's having seizures by the seizure shore. Well, let's look at all the things that cause delirium and altered mental status. Delirium, altered mental status. So what's the difference between stupor and delirium versus a seizure? So the answer is the intensity of the abnormality. The things that cause stupor and delirium, altered mental status, whatever you like the way you say it. You could say stupor, sleepy, coma, disoriented, change in mental status, altered mental status, obtunded, whatever way you learn to say, hey, she don't think it's so good. She don't think it's so good. The things that cause delirium and stupor, things like sodium disorders, high sodium, low sodium, low oxygen, low glucose, calcium, glucose, sodium, oxygen, calcium. All of these things cause altered mental status to cause a delirium. Now, the difference between that and dementia. Dementia is like this. People be like, hey, how you doing? Nice to see you again. People cover for their dementia by saying, nice to see you again, because you don't actually know that they know what your name is, do they? They don't know. Nice to see you again. Have you ever met me? No. How do you know? What's my name? Nice to see you. How you doing? What did I just do? I don't know. What's my name? Who are you? What am I? Where are we? Now that's different than delirium. Delirium is that's the difference between that and delirium. You see, these things don't cause dementia. Altered mental status, sodium, glucose, liver and renal failure, hepatic encephalopathy, uremic encephalopathy, drugs and toxins, and things inside the brain. Well, the difference between delirium, stupor, obtundation, is that when you have a person who's presenting with a seizure, all of these things, including CNS infections, all of these things have to be tested for, because delirium and stupor and altered mental status with sodium, oxygen, glucose, calcium, liver and renal dysfunction, drugs, any anatomic abnormality in the brain can all cause seizures. The worst form of delirium and stupor is a seizure. The worst form of delirium and stupor is a seizure. The worst form of delirium and stupor, the worst form of delirium and stupor is a seizure. And that's why when the person comes in and they've had a seizure, you need to exclude all of these things. Now, you can even saw this. I saw this today. A person who had a very severe hypertensive crisis was confused, and they actually seized from that severe confusion from a hypertensive crisis. And that's why the best initial tests for seizures is everything you see here, plus the CT scan of the head, in order to determine the etiology. When someone has a glucose, sodium, oxygen, calcium, rarely magnesium disorder, that's not epilepsy. Epilepsy is not a person who's hypoxic and hypoglycemic causing a seizure. Epilepsy is not a person in hypertensive crisis causing a seizure. Epilepsy is a person who has a seizure disorder of unclear etiology. Epilepsy is a person who has a seizure disorder of unclear etiology. You're having seizures and I don't know why. You're having seizures and I don't know why. That is what epilepsy is. Epilepsy is a seizure disorder of unclear etiology. Now, a person comes in and they've got status epilepticus. Now, status epilepticus can be of a seizure type where you could say you're having a generalized tonic-clonic seizure. It could be status epilepticus with a generalized tonic-clonic seizure. Okay, the whole body, you lost consciousness. It could be a partial seizure, and you could have status epilepticus of a partial seizure where a guy's just twitching one arm. I saw that last week. Just his arm. His arm just was doing this. And he's having a seizure. And he's awake. He was awake. Simple, meaning that you're awake. Simple, meaning that you're awake. Complex, meaning you're not awake. Simple, now you're awake. Complex, you have a loss of consciousness. And he had a simple, partial seizure that was status. He kept twitching that arm. He was awake. The rest of his body was okay. But that was a type of status epilepticus. The status epilepticus that most people will refer to on your test is a generalized, persistent, tonic-clonic seizure. Now, this is the only form of seizures that has a really clear answer. For instance, what is the best long-term anti-epileptic therapy? We do not know. What is the best anti-epileptic therapy for people who are pregnant? We don't know. There's no answer to that question. Now, because we're in the business of preparing you for your boards and your standardized tests, we have to come up with an answer. And we can't give you one answer, so they're not going to ask you that question. They're not going to ask you an unanswerable question like, hey, what's the best seizure medication in pregnancy? When nobody knows. We could tell you what's the worst in pregnancy. We could tell you that in pregnancy, valproic acid is the worst. We can tell you that the worst one is phenytoin. The worst one is valproic acid. We could tell you that valproic acid and phenytoin are the worst. Why are they the worst? Because they interfere with folate metabolism. They're the worst because they interfere with folate. That's why they're the worst. Now, what is the best? Nobody knows. How long, okay? Which is the best long-term anti-epileptic? Is it phenytoin? Is it carbamazepine? Is it levetiracetam? Is it oxcarbazepine, valproic acid, lamotrigine, pregabalin? Nobody knows. The only truly clear answer is status epilepticus, because there's a clear answer. Benzodiazepines are first. So sometimes what happens is that the medical students preparing for this test will think that they're going to ask you this totally unanswerable question. They're going to ask you a question like, what's the best in pregnancy? And give you the 5 choices that are all equal. But they're not going to do that because they can't do that. You think the people who are making your test don't know that your career moves forward or doesn't move forward based on this grade? You think they don't know that? Like, hey, yo, Bob, did you know that, like, your SMLE scores, like, actually determine if you get ophthalmology? And, like, do you match at all? Really? I never thought about it. Of course they know. Of course they know. So we can't ask you a question that's unanswerable. They'll ask you a question that's answerable. Which of the following is the most dangerous? Now, the best initial therapy for status epilepticus is lorazepam, a benzodiazepam. Lorazepam, a benzodiazepam. Lorazepam. Okay, it didn't get better. What do I do then? Phenytoin. Phenytoin. Very clear. It's very clear. It's a clear answer. Everyone would agree. Lock 10 neurologists in a basement, and all 10 of them will send benzodiazepine first. Lock 10 neurologists in a basement, and 10 neurologists will say phosphenatoin second. Clear. It's a clear answer. Now, what's the difference between phosphenatoin and phenytoin? Phosphenatoin is phenytoin that's metabolized to phenytoin, but it does not have the AV block and does not have the hypotension that you get with phenytoin when you give phenytoin quickly. See, phenytoin is a class 1B antiarrhythmic. Phenytoin is in the same class as lidocaine. Phenytoin is in the same class as lidocaine. So therefore, it can cause hypotension and AV block. But phosphenatoin is a precursor. Phosphenatoin is a phenytoin that you can give, and it waits to be metabolized to phenytoin. Then, if you're still having a seizure, phenobarbital. Okay, phenobarbital. Okay, Phenobarbital is useful for stopping seizure. Most of the time we don't get down there. But what if ultimately none of these things work? Well, then it's time to do neuromuscular blockade so you can intubate people. Neuromuscular blockade, which is a succinylcholine. Neuromuscular blockade, which means to paralyze the patient. Vecuronium, pancuronium, succinylcholine, vecuronium, pancuronium, succinylcholine, vecuronium, pancuronium, succinylcholine, neuromuscular blockade. But remember, just because you stop the muscles from contracting, it doesn't mean that they've stopped seizing inside. Just because you stop the doinky, doesn't mean they've stopped seizing. It means that they're seizing inside. Their brain is cooking. They've just stopped the external manifestations of muscular contraction and allow you to intubate them and put them on general anesthesia. General anesthesia, midazolam. General anesthesia, propofol, pentothal, thiopental, propofol. General anesthesia, where you put them on a ventilator because you can't give things like midazolam or propofol without intubating them, because everyone knows propofol would stop your breathing. Everyone knows you have to be put on a ventilator. That's a medical student level of knowledge to know not to use propofol at home for someone's sleeping pill. Propofol kill you. So status epilepticus is very straightforward. Status epilepticus is lorazepam, fosphenytoin, phenobarb, then general anesthesia. Very clear. It's a medical student's dream. 1, then 2, then 3, then 4. It's fantastic. 1, then 2, then 3, then 4. It's fantastic. Very straightforward. What's the best long-term medication? Oh, man, I don't know. Phenytoin, carbamazepine, oxcarbazepine, valproic acid, levetiracetam. Do you know why you're going to see Keppra, levetiracetam used all the time? If you're a current 3rd or 4th year student, you're seeing Keppra, and I don't, it's not that you're tested on brand names, you don't test on brand names, but that's what you'll see it, because levetiracetam is a very long name. Drug companies love long names because then their manufacturer's name is easier to say. Levetiracetam or Keppra. You see that drug used because it has very few side effects. And that's why most people will use this first, because if what you do first on you're choosing your drugs, first is efficacy, benefit. Does it work? Number 2 is adverse effects. And since the drugs have the same efficacy, levetiracetam, Keppra, has fewer adverse effects and doesn't require therapeutic drug monitoring. Because therapeutic drug monitoring is a pain in the ass. Is it too high? Is it too low? Just give it and you're done. Just give it and you're done. Now, next points about seizure disorders is that when can you stop? When can you discontinue? And the answer is nobody knows. But we go 2 to 3 years seizure-free, and then we consider telling people to stop. After 2 or 3 years of being seizure-free, tell people to stop. Next is you should not be treating a first-time seizure. You should not be treating a first-time seizure unless there's something really bad in the circumstances that makes you think they're going to recur. You should not be treating a first-time seizure unless there's something that says, this person, you better put them on drug, man. You better put them on drugs or they're going to come back, going to bite you in the ass. You treat first-time seizures if people come in status epilepticus. In other words, you think that people all come with status epilepticus because that's what you see on TV, that's what you see in the emergency room. It's selection bias. It's selection bias of the people who have status. But most people have a brief seizure at home or work and it stops on its own. But if the person's seizure does not stop until they got brought in to see you as the doctor until you stopped it with medications, benzodiazepines, phosphonatoin, phenobarbital, that's really bad. That means they're going to recur. It's like a person who shoplifts, and you have some teenager who shoplifts because he wants to see if he can get away with it, is different than someone who continues to steal until they're caught and arrested. Status epilepticus, they're going to recur. Next thing, people have some cause that can't be fixed. An uncorrectable cause. They have a brain lesion that's uncorrectable. They have a brain tumor that can't get better. They got a meningioma that's not going to go away. I have an uncorrectable cause. Those people are going to recur. Those people are going to recur. They have an uncorrectable cause. They're going to recur. You better give them some treatment before they recur. Occasionally, people have a really strong family history. They're from a family of seizing people. You go over for dinner at the house, and they go, how you doing? I'm fine, 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 fine. Hi, Mom, how are you? Good, honey, 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 honey. Grandpa, what are you doing tonight? I don't know. So you have a really strong family history of all seizing people. It's going to recur. And lastly, why do we do the electroencephalogram? Why are we doing the electroencephalogram in people who have that seizure? Well, you could say, what if I'm not sure it's really a seizure disorder? There's a good one. I'm not sure. I get an EEG because I'm not sure. But why get an electroencephalogram in someone that you know had a seizure? We saw the person seizing. Why do we need an EEG? I saw them seizing. Ooh, because a lot of people, particularly as adults, don't recur. This is one of the things people don't understand. They don't understand that most people who seize as an adult don't recur. What do you mean? I thought it was epilepsy. Well, epilepsy usually starts as a child. Epilepsy starting at 40 and 50, that's like starting to take up, like becoming an asthmatic at 50. Not too much. An asthmatic at 50, I don't think so. Oh, what started happening? More people will start to take up oil painting in their 50s than will become asthmatic. So people who start seizing as adults, a lot of them never have a second seizure. So get an EEG. If the EEG has got an abnormality, then you treat with the first time seizure. Now, the final thing that I'm going to say to you about seizures is something that you're going to violently, many of you disagree. But then again, look, I don't make the news, I just report it. And you can disagree all you want, but it's the answer. It's about driving. You can't take away people's licenses. You can't impound their car. There's not even mandatory reporting to motor vehicles. There's not even a standard length of time that you tell people to stop driving. The laws on not driving with seizure disorders is that you say to people, don't drive. Now, you're going to disagree with it. You're going to, a lot of you are going to say, you should be reporting to motor vehicles. You should be able to do all sorts of things. And I understand your point, but the difference between law and medicine is that laws are different state by state. Medicine is not. Spironolactone is good for congestive failure in all the states. ACE inhibitors are good for congestive failure in all the states. So that's why USMLE and COMLEX can be national and, in fact, international exams, because human physiology is international. But laws like how long not to drive, that's local. That's why lawyers have to take a state-by-state examination. Aren't you glad you're not a lawyer? There are probably other reasons you were glad, but that's an even better reason not to be glad not to be a lawyer. So you don't have to agree with me, and you can persist in thinking, I should be able to take their license, report them to motor vehicles. But you can't. You can't. And you might say, well, where's the ethicalness in that? You go, well, when you agree to get in a car, you agree to take upon yourself the risk of driving. Period. That's the way it is. So let's say that I tell you something that you never heard of, or that you disagree with, or that you don't like. You don't have to agree with me in the things that I put forth in my books. You don't have to agree with us in the things that we give you in this course. But when it comes to test day, answer what we tell you, because it's going to be right. So I might say that you could be on test day and you get to a question where in your heart you don't agree with something I said, like the driving thing. Can you have enough faith in us and me that you can answer something you don't believe in and still get the question right? And the answer is yes, because we will not let you down. I am not going to let you down. You could trust the answers we're giving you. And in your heart, you can disagree with me. And you don't even have to like me. But on the test, answer what I'm telling you, because it'll make a better you.